Assalamu alaikum. Now I would like to discuss about the presentation, fetal growth retardation and weight change regarding obstetrics, 10 page at a row. It's a series of lecture where I can starting these topics and try to clear the doubts regarding these topics. Okay, first of all, presentation. If we look at the presentation, if you look at the fetal presentation, it's the relationship. It's the relationship of fetal presenting part to the maternal pelvis. What is fetal position? It's the relationship of the fetal presenting part to the maternal pelvis. Fetal presenting part to the maternal pelvis. Okay, the optimal presentation of optimal presentation is occiput anterior. The optimal presentation is occiput anterior because it facilitates the cardinal movements of the lever. Because it facilitates the cardinal movement, this is occiput. This is occiput anterior. This is the sacrum. This is pubic symphysis. This is pubic symphysis. This is sacrum, and in here there is occiput. This is occiput anteriorly. Occi this is the coronal suture. This is the sagittal suture, and this here is pubic symphysis. This is occiput, and it is anterior. The optimal fetal presenting position is occiput anterior because it facilitates the cardinal movements of the lever. Deviation from this position, occiput transverse, can cause cephalopelvic disproportion. When it happens in the second stage of labor. Simple. In second stage of labor, what happens if there is a position deviation? When it happens in the second stage of labor. So fetal positioning, what does fetal positioning mean? It's a relationship of the fetal presenting part to the maternal pelvis. It's a relationship between the fetal presenting part with maternal pelvis. Most optimal position. The optimal position is occiput anterior because it facilitates the cardinal movement of the lever, and deviation from this position can cause cephalopelvic disproportion. This is right occiput anterior. This is the left occiput anterior. This is occiput anterior. Legs. This is left occiput transverse position. And these can cause cephalopelvic disproportion. These can cause, this is occiput, this is maternal pelvis, and these can cause cephalopelvic disproportion. Very high health. It's a very basic but very high health. Transverse line. When the fetal spine when the fetal spine is perpendicular, when the fetal spine is perpendicular to the long axis of the uterus, common in early gestational age. Transverse lie can happen in early gestational age. Most fetus spontaneously convert to longitudinal lie. This is transverse lie, and it can convert to longitudinal lie. And cephalic presentation by term more than 37 weeks of gestation. Therefore, preterm transverse lie is managed expectantly with an ultrasound at term to evaluate fetal presentation. Then the breech presentation. What is breech? Breech types 3: frank, complete, incomplete. Breech, frank, incomplete, complete. This is frank, this is incomplete, this is complete. When hips are flexed and knees are extended. When hips flexed, knee extended, that means buttock positioning. This is frank breech. Complete is hip and knee is flexed. Hip and knee is flexed. So in frank, hip flexed, knee extended, that is frank. Hip, knee, both are flexed is called complete. And one or both hip not flexed. One or both hip not flexed. This is incomplete. This is single footing. This is double footing. What are the risk factors of these breach? It may happen in advanced maternal age more than 35. It may be due to multiparity, uterine didelphus, uterine leiomyoma, uterine didelphus, septed uterus, leiomyoma, uterine leiomyoma, and some sort of fetal anomaly like anencephaly, IEL, if there is preterm less than 37 weeks of gestations, if there is oligo or polyhydramnios, if there is placenta previa, these can these are the risk factor for this breach. So I'm discussing again the risk factors. This this is very high. The risk factors you have to remember for uh, for tackling the question. For tackling the question, all you have to remember is to identify the clue point, because starting at a stretch, starting from top to bottom a question, when you go through like this, you will, it's very common that you will miss some points, and then you have to the read those things again. If you do like this, if you go through like this, if you go through 7 or 8 questions like this, then lots of time will be killed, and then you will be in a fix that my times are running out, and then the easiest question will be missed. So for diagnosing, for diagnosing a disease, for diagnosing or tackling a disease, knowing the clue point, tackling the clue point, and remembering those things, and that will be very helpful for the examination purpose. But in clinical purpose, you have lots of time. You can think by yourself, you can think by as a team. So in that case, you have get enough time not to be missed. So for breach presentation, for breach presentation, what are the risk factors? If it is preterm less than 37 weeks, if the mother is aged more than 35, if there is uterine leiomyoma, if multiparity, if uterine didelphus, poly or oligohydramnios, if there is placenta previa, not abruptio, if there is placenta previa and the fetal anomaly like anencephaly can be thought. Management is ECV, that means external cephalic version, and cesarean delivery. External cephalic version and cesarean delivery. These are the things about breech. So this box is very high yield. This should be think as a witness. These are the breech. Okay. Now ECV, external cephalic version. This is a very emergency box. Is a very emergency box. You have to remember that external cephalic version procedure is manual rotation of the fetus to cephalic presentation. Externally, you will position the patient into cephalic way. That is external cephalic version. What does external cephalic version means? That means externally you are trying to make the position. You are trying to make the cephalic position of fetus and decrease cesarean delivery rate. If we can position the baby, then it will be easy. When the mom will push, the baby will go down and the delivery will happen in the easiest way. The indication is breech or transverse presentation. If the presentation is breech or transverse, if it is more than 37 weeks of gestation, these are two indications of this external cephalic version. Absolute contraindication is contraindication to vaginal delivery, contraindication to vaginal delivery like prior classical cesarean section, like prior extensive uterine myomectomy, like placenta previa. So prior cesarean, prior classical cesarean delivery, prior extensive uterine myomectomy, and placenta previa. Complications are abruptio placentae and intrauterine fetal demise. Complication is abruptio placentae and intrauterine fetal demise. These are the things about external cephalic version. So, in short, in external cephalic version, that means the we are positioning the baby, we are positioning the fetus in a cephalic position. The baby is in the other position, like he is in the breech position or he is in the transverse position, and we are making the baby in a cephalic position externally. That is external cephalic version should be done after 37 weeks. We should be done after 37 weeks. What is the absolute contraindication? Absolute contraindication should be prior a contraindication to vaginal delivery, prior classical cesarean delivery, preeclampsia, and finally prior extensive uterine myomectomy. These are the reason for external cephalic version. Complication is abruptio placentae and intrauterine fetal demise. Intrauterine fetal demise. However, in contrast to prior low transverse cesarean delivery, prior low cesarean delivery, vertical uterine incision is a contraindication to the vaginal delivery due to risk of uterine rupture during labor. It's an obstetric emergency. So, in contrast to a low transverse cesarean delivery, in contrast to our low transverse cesarean delivery, prior cesarean delivery via vertical uterine incision is a contraindication of the vaginal delivery because it can rupture the uterus. External cephalic version is typically performed with or without 37 weeks of gestation to manually correct fetal malposition. Rupture membrane, decrease amniotic fluid, and fetal prematurity all are relative contraindication to external cephalic version due to a lower success rate and high rate of fetal injuries. So these are the relative contraindication. And the final internal podalic version facilitates vaginal delivery. Internal podalic version facilitates vaginal delivery of the second twin by grasping the free and performing a breech extension. It is not indicated in the management of singleton gestation. Then fetal growth restriction. Fetal growth restriction. It may be symmetric, it may be asymmetric, it may be symmetric, it may be asymmetric. Fetal growth restriction may be symmetric, may be asymmetric. What does symmetric means? Ultrasound estimated fetal weight less than 10th percentile. Ultrasound estimated fetal weight less than 10th percentile or birth weight less than 3rd percentile for gestational age. Ultrasound estimated ultrasound estimated fetal weight less than 10th percentile and birth weight less than 3rd percentile for gestational age is known as symmetric fetal growth restriction, and asymmetric is just like the same ultrasound fetal growth restriction. Asymmetric happens in the second and third trimester, symmetric happens in the first trimester, and symmetric ultrasound estimated fetal weight less than 10% of the birth of the less than ultrasound estimated fetal weight less than 10th percentile or birth weight less than 3rd percentile of the gestational age. Okay, etiology for symmetry. This is chromosomal abnormalities and congenital infection. Chromosomal abnormalities and congenital infection. And asymmetric is uterine placental insufficiency like hypertension, pregestational diabetes, and maternal malnutrition and maternal malnutrition. Clinical feature is global growth lag for symmetric, for asymmetric head sparing growth lag. In symmetric, there is weakly biophysical profile, serial umbilical artery Doppler sonography, serial growth ultrasound, monitor or treat complications like hypoglycemia, hypothermia, hypocalcemia, polycythemia. These are the things for management. These are the things for symmetric management. Fetal growth restriction. This is an emergency chart from this topic. Lots of question comes from this topic. It's a very unpredictable to understand because I actually don't remember the simple things as a row like so symmetric growth restriction. The risk factors are chromosomal abnormalities and congenital infection, double C's, and asymmetric is uteroplacental insufficiency due to hypertension, pregestational diabetes, and maternal malnutrition. In symmetric, there is global growth lag, and in asymmetric, there is head sparing growth lag. Patients with fetal growth restriction have higher risk of intrauterine fetal demise and require patients with fetal growth restriction have a higher risk of intrauterine fetal demise. Animated umbilical artery Doppler sound to assess the placental perfusion. These measurements are used to identify who require urgent delivery to minimize the risk of fetal demise. Weight gain in pregnancy less than 18.5 should be 12.7 to 18 kg. For normal BMI like 18.5 to 24.9, there should be 11.4 to 16 kg. 11.4 to 15.9, that means approximately 16 kg. So 12 to 18, then 2 less, 1 less, that means 16 and 11, then 16 and 11, 25 to 29, 6 to 11.4, and more than 35 to 9. What are the complications if there is ideal if ideal weight is not gained? If ideal weight is not gained, what should be the complications? If there is inadequate weight gain, there may be low birth weight, fetal growth restriction, preterm delivery. If there is excessive weight gain, there may be GDM, there may be fetal macrosomia, there may be cesarean delivery. If there is inadequate weight gain, there may be low birth weight, fetal growth restriction, preterm delivery. If there is excessive weight gain, there is gestational diabetes mellitus, fetal macrosomia, and cesarean delivery. During pregnancy, women have increased nutritional requirement. Both calories and nutrients are preferentially shunted to the developing fetus. To meet these metabolic demands, average women should increase their intake. Average women should increase their intake by approximately 350 to 450 kilocalorie per day. 350 to 450 kilocalorie per day in the second and third trimester. The target goals for gestational weight gain depend on pre-pregnancy BMI, which is an indicator of baseline maternal fat and nutritional store. Unlike adult anemia, which is commonly due to iron deficiency. Fetal anemia is typically occurs. Fetal anemia is typically occurs due to fetal red blood cell destruction. Common causes of RH, alloimmunization, and parvovirus B19, which is cytotoxic to the fetal red blood cell precursor. Fetal anemia is not due to decreased fetal weight. That's all. We will discuss the next topic in the next lecture. Hope you enjoyed.